right?
Yeah, I'll send it to you.
Okay, attendees are starting to come into the room. We'll give them a few minutes. We'll give them a few minutes to get in. So maybe we can start in a couple of minutes.
Okay.
Thanks, David. Thanks, Dr. Richeimer.
So
I'll be on afterwards if you can stay on for a couple of minutes.
in order to do the webinar, do I stay here or do I have to log into a different?
Just
No.
stay here.
Okay.
Yeah.
Okay, I see everyone is starting to log on. So good evening, everyone. My name is David Goldeisen. Welcome to our webinar with Dr. Stephen Richeimer tonight. The topic is alternatives to opioids. So we'll give about 25-30 seconds for everyone to get logged in. Dr. Richeimer, looks like we can't see the attendees, or they're going to be in a separate box. I can see them.
Yeah, they're in a separate box. We already have about 40 in attendance. We should have a few more, maybe in a few minutes.
Will I be able to see the attendees?
If you go to the participants tab, click on that, you should be able to see their names on there.
You just see the names. You won't see they won't
get it.
you won't see them. No.
Okay.
Okay, so I'll do a quick introduction here and we'll get started. So again, welcome everyone. I do see some familiar names here, so thank you for joining us tonight. If you don't know, Dr. Richeimer is the director of our online pain medicine master's and certificate programs, which is a collaboration between the Keck School of Medicine and Ostro School of Dentistry here at USC. So just real quickly before we get started, my name is David. I'm going to go ahead and put my email address in the chat box, and we're always happy to talk to anyone who's interested to learn more about the programs. So feel free to reach out directly to me at any time, and I'll be happy to have a Zoom conversation or phone call with you down the road. In terms of housekeeping, this presentation will be about 40-45 minutes, and then we'll have time at the end for questions and answers. During the presentation, if you do have questions that come up, feel free to put it in the chat box and we'll get to them at the end of Dr. Richeimer's webinar. So again, in the chat box, I'll put my email address.
David, can we also remind everyone they need to take the post test?
Right, so if you are here to seek CE or CME credit, just listen out for a special code word that we're going to announce during the presentation, and I'll put it in the chat box. And in order to obtain that CE CME credit, you are going to have to take an assessment at the conclusion out of this webinar. So I believe Hasmik and Dr. Vistoso will be able to share more information about that towards the end of tonight's presentation. Okay, great. So without further ado, I'll turn it over to Dr. Richeimer.
Great. Pleasure to be here in the new world of being on my computer to speak to you all. So what we are going to be talking about today is the treatment of pain, and in specific, alternatives to opioids. So hopefully this is visible for everybody, and we'll save some time at the end for questions.
Yes, it is. Great.
Now I just have to figure out why it's not advancing. There we go. Okay. So first of all, the question is, why do we want alternatives to opioids? Why do we want to avoid them when possible? And so the first question is, do they work? What percentage of your patients on opioids are getting effective relief? And I would suggest that at least for chronic pain, it's not going to be really good. And then come all the issues of the side effects. And here I list some of the big ones. And then, of course, what we hear about all the time in the media is addiction, the risk of addiction and the risk of overdose. But I'm also going to be talking about another issue, which I think in some ways trumps these, and that is that long-term use of opioids, maybe even short-term, can worsen pain. Okay, so first, let's talk a little bit about the CDC guidelines. These are from the original guidelines. They've modified it a little bit, but really these things that I'm listing here are really still stand. And that is that we want to use non-opioids for chronic pain whenever possible. And that's because there's evidence that you get as effective relief. They're better tolerated. Patient function is actually better without opioids and using other analgesics. When we're dealing with acute pain, we want to try to limit the duration. Certainly, there's more flexibility than 3 to 7 days. Depends on the kind of acute pain. And we want to avoid, whenever possible, mixing opioids with benzodiazepines. That combination is associated with a fourfold increased risk of overdose death. Okay, this is getting at the issue I was talking about before, the increased risk of pain. So what we're looking at here is a schematic of a dorsal horn synapse. We're in the spinal cord, we're in the dorsal horn, and this is a nerve fiber coming in from the top, from a sensory or an afferent fiber that transmits pain. Not all fibers transmit pain, but from a pain transmitting fiber. And it's going to release these striped neurotransmitters, glutamate and substance P and others, which are going to cross the synapse and bind onto the second synapse and cause a signal to propagate up the spinal thalamic pathway to the brain and lead to the perception of pain. This synapse has all kinds of things going on, as you can see. These solid ovals are inhibitory receptors. And so you can see that opioids bind to these mu receptors and these delta receptors and kappa receptors that are both presynaptic and postsynaptic. And that gets us to our standard understanding of opioids, which is that opioids reduce pain by presynaptic and postsynaptic inhibition. But in the last 10, 15 years, we have learned that there's more to the story. And that's that funny thing that is on the top of my slide on the left there, which is a piece of insulation, which is my symbol for the glial cells that surround the nerves and actually in some ways are the nursemaids of these sensory fibers. And glial cells can be activated. And when glial cells are activated, they can release inflammatory neurokinins and others that actually irritate, if you will, the pain transmission nerves, making them more likely to fire and increasing the experience of pain. So here's a little bit of a schematic showing that we have on the left side our presynaptic and our postsynaptic neurons. And off to the right side, we have a glial cell that can be activated, different things activate it. And when it's activated, it releases inflammatory mediators onto both nerves, nerve cells, and increases the pain signaling. So this is just showing you what activates the glial cells, and there's all kinds of things, but at the top, you'll see here opioids. It turns out that injuries also activate glial cells. So the combination of injuries and opioids might be a particularly potent activator. So what we're dealing with here is that opioids both inhibit and increase or facilitate pain transmission. So I explain to my patients that I am trying to have them, um, I'm trying to have them participate in the process of weaning down their opioids and maybe getting them off of opioids entirely. I explain to my patients that typically I'm not worried about addiction and overdose. Some of these patients have been on opioids for years, and they've done so, in a proper way. They take their medicines properly. They're not addicted. They're not overdosing. So they don't relate to that. But when I explain to them that they are driving down the highway with one foot on the brake and one foot on the gas at the same time, that they can understand, and they can now appreciate that maybe there's a benefit to them trying to get off of these opioids. Okay, so what do we mean by opioid sparing? What will help us do that? And essentially, all of our non-opioid medicines that we use in our business can help with this. Sometimes they can replace opioids. Sometimes they don't replace opioids, but they enhance the opioid effect and thereby allow us to decrease the dose. This is a time when polypharmacy, done carefully, can be useful. And it's also a time to remember that not only drugs can be part of this plan, other treatments such as physical therapy, occupational therapy, pain psychology, devices, procedures, all of these are non-pharmacologic options. Okay, so just to go over a couple of studies, this is a study that came out in JAMA. It's now 6 years old, time flies. And it reviewed non-opioid treatment versus opioid patients, and found that they did not differ in terms of how well they were functioning, but that the pain intensity was actually improved more in the non-opioid group, and that adverse side effects were much more common amongst opioid treated patients than non-opioid treated patients. Here's another study that's looking at paracetamol, which is acetaminophen, versus a oral analgesic that was a combination of opioid and acetaminophen. And so what they found was that combining the acetaminophen, ibuprofen, and codeine was not better than just using acetaminophen alone. And that, in fact, you had more side effects when you used a codeine combination drug. Okay, so let's talk about what are some of the alternatives. So most common are NSAIDs and acetaminophen. And in the emergency room, This study showed that a single dose of oral opioid versus non-opioid was roughly equally effective. For more chronic pain, we might think about using anticonvulsant and antidepressant medications. And then also, probably more common in the chronic pain world is using topicals such as lidocaine creams or patches and NSAIDs creams or patches. There's other categories of drugs that we use as, again, pharmacologic alternatives. NMDA receptor antagonists, we'll talk more about this, but the classic one is ketamine. Low-dose naltrexone, metformin, muscle relaxants such as tizanidine and baclofen, sympatholytics, and cannabinoids. Some things we know a little bit more about than others, so we'll review some of this. So the most common medicines that we use to treat neuropathic pain or chronic pain caused by nerve malfunction. Typically, acute pain is usually nociceptive pain. It's an injury to the body. The nervous system is properly sounding the alarm. Chronic pain more commonly is neuropathic, coming from the nervous system improperly sounding the alarm, meaning there's no injury going on. So for neuropathic pain, the most common drugs are these, which I call the big three. Gabapentin, also known as Neurontin, pregabalin, also known as Lyrica, and duloxetine, also known as Cymbalta. And I give here common recipes for doing this. Later, I'll just check if people will have access to my slides. It's okay with me. Okay, then so that was kind of dealing with the anticonvulsant and antidepressants. Though there are other anticonvulsants and antidepressants that can be used. Next, we can think about using lidocaine, particularly in topical form, though we do also do IV lidocaine for certain cases. The lidocaine patch is officially indicated for the treatment of postherpetic neuralgia, but can be used for other localized pain. You can apply up to 3 patches at a time. Depending on which company is making your patch, these patches can be cut. If it's the original Lidoderm, it definitely can be cut. And these are kept on for 12 to 18 hours out of 24 hours. And typically there's 12 to 6 hours of a break, skin airing out, if you will. And then they can be reapplied, a new patch reapplied. So it's interesting that lidocaine is a medicine that blocks the sodium channels. So one of the sort of exotic, if you will, causes of pain is a disease called erythromelalgia, which is a condition where the patient has widespread pain throughout their body, but worst in their feet. It's a burning pain. And these patients have a mutation of their sodium channels that gets stuck in the open position. So sort of the opposite of lidocaine, if you will. So lidocaine is just one of a number of topical medications. Capsaicin, which is the ingredient in cayenne peppers, can be used, though I very rarely try using it because I have not had good success with it. NSAIDs, diclofenac is the most common one that is commercially available both in creams and in patches and in drops. The Voltaren cream is diclofenac, and that is now available over the counter. Sometimes we compound ketamine into creams, or gabapentin also can be compounded into creams. Camphor and menthol are typical agents in over-the-counter creams, but they can also be compounded. And on a rare occasion, we'll actually compound opioids into a cream. Okay, so let's talk a little bit about this interesting category of NMDA receptor antagonists. So these are really the main ones that are available to us as existing drugs: ketamine, memantine, amantadine, methadone, and dextromethorphan. The strongest of these is ketamine. Ketamine is not available orally as a commercial product. It has to be ordered from a compounding pharmacy. Or occasionally, you can actually give the liquid that would be injected, the fluid that would be injected, and have the patient mix it with something to disguise its bitter taste and drink it in obviously controlled doses. So the NMDA receptor complex sits in the membrane of nerve cells, and this is in its resting state. This is a channel which is plugged by the magnesium ion. And when there is a pain signal from the first order neuron in that synapse we talked about at the beginning, those neurotransmitters, glutamate specifically, will cause a deformation of this complex and kick out the magnesium plug. And now calcium can enter through this channel, and calcium entered into pain transmitting nerve cells acts as a promoter of pain and a sensitizer of that nerve cell. So generally, we want to stop the calcium from coming in. So if the magnesium plug is gone, then PCP could be given, except for PCP is a highly illegal drug. And ketamine is an analog of PCP, very similar to PCP, and it will plug this channel similarly. So other drugs that will do that are, again, the memantine, amantadine, and methadone. This gives you some of the ways that sometimes we use it. 10% ketamine in a topical gel, 10 to 50 milligrams given approximately 3 times a day. That's oral. Or it can be given IV. You have to have sort of a whole treatment protocol for that, of 25 to 400 milligrams spread out over a 4-hour infusion. And then these other drugs are maybe not as strong as oral ketamine or certainly IV ketamine, but they can be used. Methadone is close to the only opioid that has a NMDA receptor blockade effect, which might make it more useful for neuropathic pain than other opioids. It's a tricky drug to use if one is not used to it, because the dose equivalence to other opioids varies depending on how much tolerance there is. So it can be very dangerous trying to switch a patient from other opioids to methadone if they have some degree of tolerance. Low-dose naltrexone. So naltrexone is an opioid blocker, been around probably 30, 40 years to treat heroin addicts. But it turns out that little baby doses of it are used as a, let's say, a neuronal anti-inflammatory. And what do I mean by that? I mean that we have to think about the glial cells again. And the glial cells can act as inflammatory agents. And so if we can stop the activation of glial cells, then in a sense, we're acting like a neuronal anti-inflammatory. And glial cells are activated via a receptor called the toll-like 4 receptor. And that can be blocked by naltrexone. And typically we only need and only want to give very low doses. If you're treating a heroin addict, you're talking about a 50 milligram dose. The standard dose of low dose naltrexone is 4.5 milligrams once or twice a day. I would say a very high percentage of my patients I give low dose naltrexone to as part of their treatment protocol. It is only good with patients who are not taking opioids. Otherwise, they'll block each other. The low dose naltrexone will block the opioid, and the opioid will block the effect of the low dose naltrexone. There is a whole question, can you give even smaller doses, what's called ultra low dose, to patients taking opioids? And we do try that sometimes, giving 100 to 200 micrograms instead of 4.5 milligrams. I'm not yet convinced if ultra low dose works. In metformin, there is some interesting data that metformin may be beneficial for chronic pain from a whole bunch of different diagnoses: neuropathy, arthritis, diabetic neuropathies, migraine, fibromyalgia. It seems to activate the AMP protein kinase receptor, or really it's activating the protein, and that may be useful in the management of chronic pain. We're still learning about this. So the next slide really says it is effective in reducing C-reactive protein, more so than placebo. But interestingly enough, you can get even more reduction of C-reactive protein by changing lifestyle in terms of diet, exercise, etc. Patients who are taking metformin because they are type 2 diabetics report having less chronic pain. Metformin might decrease the activation of the glial cells. Again, that's kind of an ongoing theme here. A note of caution, chronic use of metformin may affect vitamin metabolism, so you may need to supplement. Some patholytics. So alpha-2 agonists, such as clonidine, terazosin, and tizanidine. Tizanidine is a muscle relaxant, but it also has alpha-2 agonist properties. These drugs bind to the alpha-2 receptors, which you can see are inhibitory of both presynaptically and postsynaptically of the pain signal. Interesting story with beta blockers. So there is some evidence in the world of genetics research that humans have different versions of catechol-methyltransferase, COMT. And humans have different versions of this enzyme. Some versions are inefficient and do not break down catecholamines as efficiently as other versions. And it seems that patients who have, by low COMT, I mean low efficiency, they seem to have increased circulating catecholamines, which may be associated with increased anxiety, increased muscle tension, and increased pain. So for these patients, it may be that treating them with propranolol blocking the effect of these circulating catecholamines may have a analgesic effect. And there is some data to support this. I would say still a relatively small amount of data, but encouraging. Botulinum toxin. So botulinum toxin is famous because of its muscle paralyzing abilities, but which it does by blocking acetylcholine release at the neuromuscular junction. But it also inhibits the release of other neurotransmitters from the sensory nerve terminals, particularly our pain-related neurotransmitters of glutamate, substance P, and CGRP. And so we're finding that it may have a role for treating pain. This is most well established for migraines, and in fact is an official FDA indication for the use of botulinum toxin. So here I say almost ready for prime time, meaning the data is still relatively small. Excuse me, that oxytocin, also known as Pitocin, might be inhibitory of pain. The doses are 20 to 80 units, given either nasally or in a lozenge form, sublingually or buccal. And I do use this with patients, and I would say I'm probably getting maybe a 50-50 hit rate, which if that was formal in a study, that would be pretty effective, but that's just anecdotal. That patients do find it useful, not as a drug that eliminates pain, but as a drug that reduces their pain maybe 20%, something of that. But so it's part of a more comprehensive program. It also has to be compounded, by the way. It's not available in these forms. It's only commercially available IV. Vitamin C, there's some information that it decreases the requirement for opioids in post-surgical cases or in patients with bone metastases of cancer. It may be useful for the prevention and treatment of complex regional pain syndrome, for the treatment of acute and post-herpetic neuralgias, and as we alluded to cancer pain. How's it work? Well, these are some of the thoughts that it may be a cofactor in the synthesis of some of our endorphins, that it has antioxidant properties that might be useful and as anti-inflammatory. And it's also a cofactor in the synthesis of norepinephrine and serotonin, which in the spinal cord are inhibitory of pain. Cannabinoids stirs up lots of controversy, at least when one looks at the pharmacology. It looks like they should be analgesic, because the cannabinoid receptors type 1 and 2 are analgesic and anti-inflammatory. Cannabinoids inhibit the release of glutamate in that synapse that we started with. It inhibits the release of the CGRP, or calcitonin gene-related peptide, which is very important in pain transmission. CGRP antagonists are becoming a big deal in the migraine world. THC has 20 times the anti-inflammatory potency of aspirin and twice that of hydrocortisone. So again, from this information, we would think they're pretty good analgesics. but clinical trials have given us mixed results. Some are positive, some are negative. It's not the story is not fully written yet. Um, so there are some versions that are available pharmaceutically, nabilone or dronabinol, um, but frequently cannabinoids are not the commercial pharmaceutical versions. In Canada, there are some other versions available. So, we're talking about a lot of different drugs, and sometimes polypharmacy makes really good sense here. But by word of caution, we need to be thinking about drug-drug interactions, particularly when we double up drugs that are anticholinergic or double up drugs that are sedating or double up drugs that are serotonergic because we want to avoid serotonin syndrome or double up drugs that may have QT prolongation effects. Example, methadone is a QT prolonger. Tricyclic antidepressants are a QT prolonger. So one would be careful there. Maybe altogether avoiding. So serotonin syndrome is characterized by typically increased and some instability of vital signs. The patient may reach the point of being agitated, delirious, as it says here, autonomic instability, but tending towards a hypertensive and tachycardic. They may demonstrate clonus, tremor, and can have diarrhea, increased bowel sounds. So it can be a life-threatening condition. So here on the left side, I put a list of drugs, an incomplete list. This is a partial list of the drugs that can contribute to serotonin syndrome. Some of these are common in the pain world. Antidepressants, triptans, tramadol, tricyclics, MAO inhibitors, metoclopramide, ondansetron, dextromethorphan. So a lot of these can be found fairly commonly in treating pain patients. Anticholinergic side effects, harkening back to med school days, red as a beet, dry as a bone, blind as a bat, mad as a hatter, hot as a hare. So what we see is that flushed, feverish, confused, delirious, dilated eyes, decreased bowel sounds, constipation, dry mouth. So these are signs of too much anticholinergic drug. As an aside, why are hatters mad? So since I'm not in a classroom where people can answer, I will answer for you. It comes from the old days when the people who made felt hats would cure the felt in mercury. So these workers, known as hatters, were chronically exposed to mercury and got mercury poisoning, complete with the psychosis associated with that. Okay, we're really focused on the drugs, but I want everybody to remember that non-drug approaches are a very important part of the picture of treating, especially chronic pain. So we want to do the psychological approaches, cognitive and behavioral therapies, physical therapy, occupational therapy. Think maybe about complementary medicine approaches, acupuncture as an example, and then interventional treatments where we sometimes do nerve blocks or implant devices, etc. And this is what a comprehensive approach yields. A happy patient. Right? We have the medical, pharmacological, and interventional approaches combined with the functional and occupational approaches. combined with the psychological approaches and the physical therapy approaches. And this is kind of the ideal strategy for dealing with the chronic pain patient. So for those of you who are interested in this area and would like to learn more, at USC, we offer certificate degrees in pain medicine, also in pain science, but pain science is for non-clinicians. For clinicians, it's a certificate degree, a 1-year part-time program. Or for those who want to get a master's degree, we offer a 3-year part-time master's degree. These are all online, so they really are compatible with the working professional. I hope some of you might be interested and will reach out to us. Here's our website and our email. And I think David is also sharing some of his contact information. If you email this, I think actually you will reach David. So I will pause and take questions here if people have questions. When I see there's a bunch on chat, or at least a bunch of something on chat, let's take a look.
Thank you for the lecture, Dr. Richeimer. It was great. So we have a question. Do you utilize pharmacogenomic and plasma concentration analysis, and when specifically? When you assess your patient, I think that's the question.
So we don't.
How you start the assessment to decide which treatment?
Yeah, so we do not do pharmacogenetic assessments clinically. We did run a study a few years ago where we took, I think it was nearly 300 patients and ran a genetic analysis of them and then looked at which drugs made more sense depending on their cytochrome P450 profile. So we don't do that clinically because it tends to be expensive. So I think that's in our future, everybody's future, but no, we're not doing it now as part of our clinical work.
So when you combine medication, Dr. Richeimer, like for example, when you use a low dose of naltrexone with, I don't know, ketamine, it's any, like the type of pain or the quality of pain, it's important, or how you decide when to add this drug to the conventional drug that we use, anticonvulsant or TCA, when you go to this other road?
So these can all be thought about for chronic pain. Again, the majority of chronic pains are going to be neuropathic. There's a few exceptions that come out of the rheumatologic world, but most chronic pains are neuropathic, and that's where most of these alternatives can be thought about.
Would you try this drug to avoid increase the other drugs dose, or it's like a baseline? Like for example, when you have a patient with CRPS, I know that you treat a lot of those patients. It's like kind of your baseline now. Don't increase so much of the, for example, gabapentin or Lyrica, and try these other alternative drugs like topical as well.
So if a patient comes to us on opioids, then we will start these drugs with the idea of tapering them off the opioids. And then it's kind of a long process of trying to find the ideal dose of each drug and the ideal combination, a lot of trial and error. If they're not on opioids, then typically we'll start with something like gabapentin or duloxetine, try to get that to the maximum tolerated dose. If they're getting some benefit, then we'll probably continue that and add a second drug. If they're not getting any benefit at the maximum tolerated dose, then usually we'll stop and start a new drug. And I would say very, very typically, our patients end up on 2 or 3 different drugs. But each one you got to kind of try to figure out, is it contributing to help?
To help, yeah. We have one more question from the audience. It said, more and more chronic patients are receiving short-acting opioids with long-acting medication like Suboxone, Belbuca, Methadone for acute issue like surgery or injury. What are your thoughts on managing these patients?
For acute pain, we keep it simple. Short-acting opioids, things that everybody is very familiar with, things like Percocets or Vicodins or Norcos. But the idea is you're only going to treat them for a week or two with these medicines, and then you need to taper them off. For chronic pain, we try not to use them at all. And again, that's because we're afraid of that glial activation and making their pain worse at the same time that they're getting some short-term relief. So they're taking a Percocet, and they've been doing this for months now. They take a Percocet and they feel a little bit better for a few hours, but the long-term picture is we're contributing to their pain and making it harder to treat.
Okay, and let's go for the last question, Dr. Richeimer. How does duloxetine, SNRI, compare with the modulation effect of low-dose naltrexone?
Oh, they're different. They're different. So the antidepressants, not SSRIs. So SSRIs do not seem to be effective for pain management, but SNRIs or tricyclics, both those categories of antidepressants appear to be effective. And we think the main mechanism is that they increase the availability of norepinephrine and serotonin in the spinal cord, which is inhibitory of pain. We think that's the main mechanism, but there's probably other mechanisms. Low-dose naltrexone is a completely different mechanism because it's blocking the toll-like 4 receptors on glial cells, preventing the inflammation effects of glial cells on the nerve cells. Very commonly, they can both be given, and maybe even should both be given, to help with chronic pain.
There was one more question from Shant that said, do you offer certificates for acupuncture?
Sorry, no, we don't.
No, we don't.
Okay.
You want to give the code, secret code?
Okay, yeah. So David can speak more about this, but the code is treat pain better. And I think there's a little post-exam for people to take. David, I'll turn this issue over to you.
And thank you, Dr. Richeimer. So I think Hasmik has put the link to the assessment in the chat box. So just make sure if you do want to earn or obtain your CME credit, that you go and take that assessment. And yeah, the secret code is treat pain better. So make sure that's the last question. You need to answer that. So yeah, again, thank you, Dr. Richeimer. Appreciate the audience. Looks like we had a good turnout. Looks like we had about 56 people attending. Before we sign off, again, if you are interested in learning more about Dr. Richeimer and the pain medicine programs online here at USC, please reach out directly to me. I'll put my email address up on screen. I think I can do that.
Sure.
Hopefully that works.
Yeah.
So again, my name is David Goldeisen. If you email me directly, I'll be happy to jump on a Zoom conversation or phone call with you to answer any questions you have about our programs. We are currently accepting applications for the upcoming fall 2024 semester. So classes are scheduled to start on August 21st. And the deadline to submit your application for the fall consideration is going to be July 15th. So still lots of time to get your application in. And our website is here as well as keck.usc.edu/pain-medicine.
Great.
Hasmik, I'll turn it over to you if there's anything that you'd like to comment.
I think we're good. We'll come back in the fall with more webinars.
Great.
And we have a gala coming up on May 4th. If anyone's interested, you can go to our website. I'll put our website link here. And that's about it. Have a great week.
Thank
Good
you all.
night.
It was a pleasure.
Thank
Bye.
you, Dr. Richeimer.
Bye-bye.